Okay, let's go ahead and jump in and get started. So today we're talking about PCOS. So this is one of the most common endocrine disorders of premenopausal women. So about 3 million people in the US have it. I wouldn't be surprised if more than that do, honestly. And really what's interesting about PCOS is it tends to be a diagnosis of exclusion after you eliminate any other secondary causes of anovulation or hyperandrogenism. So, sometimes, a lot of times, doctors are going to make sure you don't have a condition called hyperprolactinemia, where your brain is secreting too much prolactin, hypercortisolism, late onset congenital adrenal hyperplasia, Cushing's syndrome, thyroid disorders, or even adrenal androgen producing neoplasms also. So there's some investigation that can take place when you're not ovulating and having these irregular cycles, but typically you end up kind of getting thrown in this PCOS category. So talking about PCOS, you might have heard the Rotterdam criteria for having PCOS. There's also an NIH, National Institute of Health criteria. So we'll talk about those really quick. So basically just what it means is there's ovarian dysfunction. So there's some sort of irregular or absent ovulation. And then there's clinical evidence of androgen excess. So androgen excess is high androgens, which are male sort of dominant hormones. This is testosterone, DHEA, DHT, androstenedione. Those are the main ones. And causing symptoms such as hirsutism and acne. Hirsutism is the growth of dark hairs, either on the upper lip, the chin, nipples, kind of not the super fun places that we always see in women. Additionally, the criteria also includes the presence of more than 12 follicles in each ovary, measuring 2 to 9 millimeters in diameter. And again, this doesn't have to be present to make the diagnosis of PCOS. It's just one of the criteria. And then the NIH's criteria is super similar. It's the presence of ovulatory dysfunction, menstrual cycles that are longer than 40 days, and mid-luteal serum progesterone of less than 5 nanograms per milliliter, which indicates that you're likely not ovulating. And also that can be present in people with a normal cycle length. In addition to that, hyperandrogenism, so high testosterone, high DHEAS levels, and obviously an exclusion of the disease we talked about. So what's really interesting in PCOS is some people will, is I kind of find clinically, what I was just talking about before is this insulin-based PCOS, and I definitely think that that's the most common one. High testosterone levels, sometimes issues with insulin levels and hemoglobin A1C being off. It can cause, weight gain, depression, acne, hair loss, dark hair growth, irregular periods. But I also see something kind of, which is like a new term, and it doesn't technically have a terminology. I kind of call it adrenally based PCOS, which stems more from an issue with the adrenal glands overreacting to stress and attempting to keep up with adequate cortisol production because you're chronically stressed. And that looks like people with irregular cycles that may not be overweight have normal blood sugar levels, and maybe they don't have high testosterone, they just have high DHEA. So they're just kind of two different kinds. And the one thing, and we'll talk about this a little bit later on, is PCOS as a diagnosis is great, but what's really important is what's going on in your body hormonally that can be fixed to get you where you need to be. So a diagnosis is one piece of the pot, and whether you want to put a name on something or not, you can still look at imbalances and say what needs to be fixed, what's off. Okay, let's jump into questions. That was just a little overview and maybe a little more in depth than you needed. Okay, so the first question is, what can I do to reduce facial hair? How do I lower my testosterone levels? This is a great question. So when we're looking at facial hair, this is a lot of times caused by something called the hormone DHT. And DHT is created from testosterone via something called the 5-alpha reductase pathway. So this is when your body has high levels of testosterone and it's over converting into DHT. So a couple things with that. Unfortunately, the dark hairs that are there are kind of there to stay. What is important to focus on is preventing more dark hairs from growing, and making sure we're getting those testosterone levels under control as soon as possible. So that being said, so 2 answers to this question. So the first is if you already have those dark hairs present, it's important to approach the root cause, but likely you're going to need something like electrolysis or laser hair removal to permanently remove those dark hairs. Now, the other side is the prevention of preventing more dark hairs from coming, in which we want to diminish androgenic levels. There's some prescriptions that can help decrease testosterone levels, decrease the testosterone conversion. A lot of people sometimes take something called spironolactone, which is actually a diuretic that has anti-androgenic effects as a bonus. But also with herbs, there's one called saw palmetto, and it targets directly that 5-alpha reductase pathway that converts testosterone to DHT. So that herb does a really, really good job in decreasing those kind of icky androgenic side effects. In addition to that, and we're going to talk about this in a second, in order to decrease your testosterone levels, we need to make sure that we are making sure that we're addressing your blood sugar levels as well. And I'm going to explain how your blood sugar ties into testosterone because it seems kind of like a far stretch. I know, I always thought that was interesting. So, okay, here's another question. What is the difference between polycystic ovaries and PCOS? And it's exactly kind of what it sounds like. So polycystic ovarian syndrome is a combination of symptoms that cause this syndrome. You can have polycystic ovaries from different causes, but many times if you have polycystic ovaries, it's associated with polycystic ovarian syndrome. And basically PCOS is a condition in which the egg may not develop as it should, or an egg may not be released in ovulation as it should, thusly leaving polycystic ovaries. Okay, let's see. Okay, here's another question that was from Instagram. Can you have a mild case of PCOS? If so, how can you tell? And this is kind of like what I was talking about earlier, how there's kind of a couple different kinds of PCOS, and just because you don't have like that stamp diagnosis doesn't necessarily mean that things aren't going on and you're not noticing odd things with your cycle or conceiving. So, you only need 1 or 2 of these criteria in order to be technically diagnosed as this. But keep in mind, a diagnosis doesn't mean a cure. So, if you're having irregular cycles, that's your main thing. It's worthwhile investigating, where your hormones are at, where your blood sugar is at, and just digging deeper to really look for that cause. So yes, you absolutely can have a mild form without it be screaming at you. And again, there are kind of those 2 different types of PCOS. You don't have to fit into a specific category necessarily. Okay, someone asked, I've been diagnosed with PCOS and have insulin resistance and high testosterone, textbook PCOS. I also have low iron, so probably close to an anemia, low vitamin D, but I am taking supplements. She says she knows she ovulates, her luteal phase is about 15 days, but she's still not getting pregnant. Is there something else I should be considering or get tested? This is a great question. So you're on the right track, but changes are going to take time. So I would expect 3 to 6 months of consistent change in order to see improvements in your cycle, in really moving the needle on those lab values that are off. Additionally, this person said that they're taking supplements, but it's hard to know which ones they're taking. If they're just talking about iron and vitamin D, while they're super important for your health to have optimized, it doesn't necessarily relate directly to PCOS. So you need to make sure that you're doing things that are actually targeting, are we decreasing testosterone levels? Are we balancing blood sugar? Are we supporting healthy ovulation? And in addition, just because you're taking a supplement doesn't necessarily fix something. You have to be using it as therapeutic levels in order to make the changes and help the body heal the way it should, if that makes sense. So that's just a little food for thought. And in addition to this, what I also have to say to this person is, are you tracking your basal body temperature along with LH strips? We need to make sure we actually know that you are ovulating. So it's important to have all those confirmatory pathways in check. We talked about LH strips last week and the importance and value of them, but also the importance of continuing with the basal body temperature to confirm that spike, to do progesterone test strips around day 21, 5 to 7 days past ovulation to make sure that you really are ovulating. In addition to this, if you think you are ovulating, you have these PCOS symptoms, but you are ovulating, you're not getting pregnant, what else do we need to investigate? Has your partner had a semen analysis yet? Have we investigated your thyroid? How's that working? Have you had a hysterosalpingogram? Are your tubes open? Have you had an ultrasound? Is your uterus look good to go? Is it in a good position? Are there any fibroids or polyps or abnormal uterine positioning that might be preventing implantation? So I always say, using the Premom app and tracking with the LH strips, the basal body temperature, the cervical mucus, these all give us clues to what's going on. If everything's looking perfect there, what other steps could be causing the issue? So it really lets us dig in and look for the root cause. Okay, here's another good one. And I think some of you asking, I'm answering questions that were submitted ahead of time, and some of you are asking questions now in the comments, which is great. But some of them I'm answering now for you, which is great. So can a woman with PCOS take ovulation tests, which are LH test strips? Why or why not? Absolutely. But if you aren't ovulating, you're not going to see that LH spike. That being said, it's a good idea to always be testing with the LH strips. I know it's hard, especially when you have long cycles. You're taking those LH strips for so many days, but it gives you such good information on your LH. So, you can work with fertility awareness method instructors, and they can look at those LH strips and see, are you spiking a little bit? Like, are we seeing your body kind of trying to ovulate and it's just not quite getting there? Or are you getting like a gradual spike, and a big one, and eventually ovulating? So it's important to stay consistent in tracking with those LH strips. And that's why I say, focusing on, I like the easy at home strips because they're affordable, and they're a lot easier to use for a lot of days in a row to really get an idea of what's going on with your cycle. In addition to that, checking your basal body temperature, cervical mucus, and progesterone testing are also super important, so we know what the heck's going on with your cycle. So the more data you can collect about what's going on with your body, the more information you have for figuring out what's going on. Okay, another person asked, what are considered high androgen levels? So testosterone or DHES is what they're looking at. Excuse me. Okay. If you want numbers, we'll get nerdy. We'll talk numbers. So DHEA levels, we're looking for levels more than 240 in females. That being said, DHEA is a super important hormone in your body, and that it is a precursor to so many of your other hormones. That includes your male hormones, your female hormones, progesterone, it feeds into. It helps create cortisol. It's like a good precursor. So, I don't like to demonize it, but again, we do want it within normal levels. And if it's too elevated, a lot of times I'm going to be looking at the adrenals and seeing how stressed out somebody is and see what's causing that rise. Testosterone levels typically should be free testosterone should be between 4 and 10, and total should be 40 to 100. So if you're more than 100 or more than 10 free testosterone, then, we need to start looking into things because those levels are important. That being said, it's also important that we look into the hormone DHT, dihydrotestosterone, because this is that kind of nasty hormone that we get that causes not only dark hair growth around the lips, the chin, and the nipples, but it also causes male pattern baldness in females. So you can start losing hair around here. So DHT is another hormone that you'd want to check out as well with PCOS that is not as commonly checked. So that's a little doctor tip for today. And then in addition to sex hormones, it's important to look at that hemoglobin A1C. It's such an important component of PCOS, and your blood sugar being off, insulin resistance, is what actually can cause those testosterone levels to be high. I'm going to talk about that in a minute. So I always say, if your hemoglobin A1C is 5.6 or higher, we really need to do some work on your diet and get those healthy insulin levels in check. Okay. If you have not been diagnosed and have no symptoms of PCOS, is it still possible you could have it? So we kind of talked about this in another question earlier. Yes. I'm assuming this probably means this person has irregular cycles and maybe their testosterone isn't sky high, but could they still have PCOS? Absolutely. And again, it comes down to, do you really need the diagnosis to figure out what's going on? Not necessarily like dig in, let's figure out why you're having wonky cycles. Okay, this one's really important. Somebody asked, do carbs and sugar really affect fertility for people with PCOS? Yes, big time yes. Insulin resistance is the most widely understood explanation for PCOS to date. So women with polycystic ovarian syndrome possess a selective resistance to insulin. And insulin actually has an action on the theca cells in the ovary. Those theca cells are in the ovary. And by being stimulated, excess androgens create these clinical signs of PCOS. And the testosterone that's created by the extra insulin triggering these theca cells, making the extra testosterone, actually stops follicular development, stops these eggs from forming. And it also decreases development of the endometrial lining in your uterus. So it's hugely important, and the insulin resistance and testosterone balance are super interconnected, and they kind of create that chain reaction that does halt ovulation. So super important to keep carbs and sugar to a minimum, really focusing on good whole foods. Paleolithic diets are really helpful. Just really focusing on meats, veggies, and fruits that are low glycemic. So staying away from like bananas, mangoes, papayas, focusing on lower glycemic fruits like berries, and just really focusing on balancing that blood sugar. Okay. What tests are conducted to determine if you have PCOS? So we already talked about this a second ago. So they're going to look at testosterone, DHEA, hemoglobin A1C, and then also they might look at just your serum insulin level, serum glucose, as well as an ultrasound to look for those multiple follicles or cysts in your ovaries. Okay, what else? We're almost through. What is the best way to track ovulation when you have PCOS? So we already talked about this again already. Basal body temperature and luteinizing hormone strips, just like everybody else. You're just going to have to do it for longer than other people because you have longer cycles. And not every cycle you're going to be ovulating. So don't give up if it doesn't happen one cycle. It could be you're skipping cycles. It could be every third. But keep tracking and getting that data months and months and months. The more information you have, the more answers you can find, especially when you work with an expert. Okay, last question, and I think it's a really good one to end on because we talk about it a lot. Myo-inositol, what does it do and how much is recommended? And someone else had asked myo-D-chiroinositol, is it a good supplement to take for PCOS? So first of all, I'm a doctor, but I'm not your doctor. So everything we talk about here today is education for you, and just make sure you chat with your doctor before making any changes or investigating anything. But I do want to talk about myo-inositol because it is studied very well in fertility. So myo-inositol, there's two forms of it. There's D-chiro and there's myo-inositol. And what it is it's an isomer of a sugar alcohol, which is part of a B vitamin group. Basically, what myo-inositol does is it regulates the secretion of the pancreas and the ovaries. So this is going to mediate the effect of insulin in PCOS patients. And going to help decrease those androgen levels. It's going to help support ovulation. It's been studied and associated with good oocyte quality, good egg quality. Typically, studies that I've referenced have been 2,000 to 4,000 milligrams a day, usually 4,000 milligrams in divided doses with minimum side effects. So it's definitely something to chat with your doctor about, since some of you were asking about it. And actually, I'll talk to you. There was a study, and I thought this was an interesting one to share. It's used myo-inositol compared to metformin, which is also an insulin sensitizing drug, right? Which is a great one, and it's very effective. And it compared 120 women who did 1,500 milligrams a day of metformin and 4 grams a day of myo-inositol. And then the metformin group, they had a 50% spontaneous ovulation rate and had a 36.6% pregnancy rate, which is actually awesome. In the myo-inositol group, though, they had an even higher spontaneous ovulation at 65% and an even higher pregnancy rate of 48.4%. So just kind of a cool way that nutrients can actually do a really good job and sometimes perform a little bit better depending on the needs of other things. Also, I see myo-inositol and metformin used together in conjunction, and that can be really good too when used under a doctor's supervision. So great question about myo-inositol. Some people like D-chiroinositol, like a little bit of D-chiro mixed in with myo-inositol. A lot of the research I've seen supports primarily just myo-inositol, so there's your biochem lesson for the day. But that's a super good one for PCOS, and I do think it's gaining popularity. But again, when it comes to supplements, always talk to your doctor first and make sure you're being safe and it's okay for you to add those things, and buy from trusted sources to make sure what you're getting is just another important thing. But we covered so much about PCOS today. Thank you guys so much for all your questions, and I hope you guys learned a lot and have a lovely weekend. Alrighty, take care.